Good morning, respected persons. At the outset, I would like to thank the Scientific Committee of All India Ophthalmological Society for giving me this opportunity. I'm really afraid of the audience. I'm not a teacher here because the way you have answered Dr. Rashmi's question, I'm really afraid of teaching this thing. But let's be interactive and I'll try to share my knowledge with you. I don't have any problem if you are taking any photographs of my slides. It's open to you, it's for you. But rather, if you concentrate on my slides, it will be very good for you. And at the end, I'll give my email ID. You can send me your queries, or if you want the full presentation, I can send it to you. So it's yours. I don't have any problem. Matters I'm just discussing, I don't have any financial interest to any particular machine. But definitely I will be sticking on to the Humphrey field analyzer because of two reasons. One is mostly, or I can say the only machine I am conversant with, this is the Humphrey visual field analyzer. And this is the literatures and the studies are mostly based on the Humphrey visual field analyzer. What we do with the perimetry, it is the important tool to assess the visual function outside the fovea. What it does, it measures the sensitivity at different points of the retina, and ultimately, finally, you will get some printout where the measured sensitivities will be written in the decibel value. And the sensitivity is interpreted as the sensitivity of the decibel value or the stimulus intensity, where the patient is likely to respond at 50% of the time. The perimetry itself needs a degree of psyche. At the same time, there should be some intact neural pathway from right away from retina to even the motor centers. So there are some prerequisites for doing the perimetric test. Better to have the visual acuity at least 20-100, and at the same time you need patient's cooperation without any sort of disability like Parkinsonism, neck stiffness, claustrophobia and arthritis. The reason I am asking because before thinking or before ordering the perimetric test, you should think of all these things, whether the patient can cooperate or the patient's vision is such that the patient can do the visual field test. So by perimetry, you can not only evaluate the optic nerve head or for the glaucoma, the whole visual pathway you can evaluate by the perimetric test. So what are the diseases for which we do perimetry? One is the glaucoma, as you know, that's ganglion cell disease. For the glaucoma management and for the diagnosis, it is very much essential. It is often used for optic pathway lesions, including the optic nerve disorders. It is an important tool sometimes in the management of retinal disorders and sometimes to certify the visual function in rehabilitations or any program. What are the variations? Conventionally, we use white on white perimetry. That's the white background. We put a stimulus of different contrast over the background. So we usually test the differential contrast sensitivity. That is our standard or conventional. The others, non-conventionals, use like blue on yellow perimetry, or that is the SWAP shortwave automated perimetry, where against the bright yellow background we put a blue stimulus to find out the blue cone status. The others, sometimes some advocate a red on white background for studying the different, specifically the drug-induced maculopathy, and sometimes the functional test to find out the functional status of the patients. Just one point I want to highlight, in perimetry we usually get the notion decibel value. It has a wide range of decibel values from 0 to 50, but the decibel notion is to find out the sensitivity where the machine uses the stimulus intensity which is in the apostille. So the brighter, that is just the reverse, the brighter the stimulus the patient can perceive, the decibel value is the lower, or the dimmer stimulus can perceive the decibel value is higher. As you all know that the field of vision is usually said as the hill of vision. It is a hill of vision, And the perimetry or the perimeter determines the height in different areas and at the same time the shape or the extent of the field of vision. So in that way you can get, this is the temporal extent, this is the nasal extent, and in the decibel, the each area, the height is usually represented as the decibel value. Any departure from this field of vision is usually depicted as field defect, like this is the departure of the field of vision, but this is the physiological field defect, that is the blind spot. If you get a defect like this, the perimeter usually determines the area where the defect is and what is the height of that defect. Like in the infratemporal area, there is some defect, and this can be represented as a decibel value which is lesser than the surrounding values 19. And in the grayscale, you can find out that this area sensitivity is less. So this is the thing the perimeter does. If there is any defect or any departure from the field of the vision, that can identify the area as well as the size of the defect. Over the years, the methodology differs basically in two ways. One is the kinetic, the previously usually used the Goldman perimeter, and the static automated perimeter. In Goldman perimetry, the single intensity is moving from the non-sing to sing area. So if you move a intensity from this to this sing area, you will get an isopter. For each target or each stimulus, you will get an isopter like this in the whole field of vision. So the clinician just find out different types of this field of vision. But what we do in the automated perimeter or in the static perimetry, the variable intensity with a fixed target. The target is fixed, the target site is fixed. We change the stimulus intensity, and by that we usually get the individual area of sensitivity. So in perimetry, what we get? The area-wise representation of sensitivity. But with the method of automation or with the help of the machine by the StatPack analysis, we want to find out whether this measured sensitivity is out of the normal range or within the normal range. How it is done? It is done by StatPack analysis by comparison with the normal. And it find out whether that field defect or that defect is significant or not. This is the basics of choosing different machines. This is a commonly asked questions: which machine should I buy and which machine should I use? Whatever machine is used, what is the database, that depends, that usually indicates the machine is good or not. So that is your idea, that if the database is good, like a Humphrey field analyzer, it has a multi-center database and including even the Indian populations and sometimes the random sampling. So that is totally dependent on you, the which machine you will choose. But most of all the machines are based on the StatPack analysis in a similar way. So what the perimetry does is it does the field of vision area-wise representation, and with the StatPack analysis we get whether there is any defect, or if the defect is there, whether it is significant or not. As a clinician, you need to do just the correlation. What is the need of getting all together into the machine as well as the field interpretation? So it is only the automated perimetry, and you can think of the KL is already over by this. But there is some noises which produces some problem with us, because the patient may have unreliable field, the patient may have a field defect due to the learning curve, or there are some simulating condition which may mimic like glaucoma or some retinal disease which may mimic in the same way. So what we need to know the methodology and at the same time interpretation. Quickly to do what is the method, the perimeter used. Usually it measures the phobia threshold first. There is a different contrast sensitivities are used, as a different intensity stimulus is used, and when the patient perceives that, we get as the phobia threshold, which is presented in just below the reliability parameters as a threshold value, and if it is abnormal, there will be a shaded symbol. This I will talk later on about this. After the phobia threshold, the machine usually indicates the threshold value in 4 primary points in 4 quadrants, and after that it localizes the blind spot, and then the other points are tested. This is the standard protocol of the machine. How the other points are tested? Depending on the whatever the foveal threshold and at the same time the primary point threshold, it has got some extrapolation from which the sensitivity should be started. And from there, it uses the 422 algorithm. Just for your sake, I am telling, it usually increases the 4 decibel value until and unless it crosses the sensitivity area. When it crosses the sensitivity area for that particular area or for that particular patient, it again comes down by 2 and 2 till the sensitivity point is reached. So this is called 4 decibel higher, and then again goes back to 2 and 2. And this is usually in the standard full threshold test. And there are some other strategies. Regarding the strategy, I will talk to you later on. There are some other strategy which uses the different algorithm for the time management. The different formats are placed, and it is written here in the single field analysis or the overview, where the results up to 16 tests are displayed in this way, so that there will be an easy interpretation that with time it is changing or not. The other is change analysis. It compares up to 16 tests and it analyzes the indices of changes, whatever the changes from the baseline that it indicates in this way, that the box plot way. And lastly, the glaucoma change probability analysis. The Humphrey machine itself has some stable glaucoma patients database, and depending on that database, it indicates whether the changes in the subjects you are tested, which is significant or which is different from the stable glaucoma patients. That is the change probability analysis printout. The types of tests you should know, there are 2 different types of tests. One is the thresholding and one is the screening. In the threshold, it is a precise quantification of that particular area and what is the sensitivity. But screening, what it does, it indicates that whether there is a generalized defect or any localized defect. In screening, what it does, the machine extrapolates a certain amount of decibel value for each area, and the machine presented 6 decibel higher to that area. If you respond, if the subject responds, then it indicates as the point seen, and if it does not respond, it indicates the point is not seen. So, in screening test, sometimes it's useful definitely just to find out the existence and the location, and at the same time the pattern of the field defect if the patient has anything. The different areas, it is written here at the central or peripheral, and the areas are maybe 24-2, 30-2, 10-2. You have heard about this. Just to find out that this is the Goldman visual overlay, visual field overlay, just to find out the ganglion cell distribution from the center of the fovea to the outside. Each enclosed area is the 1%. You can find out the centers are more concentrated. Just to find out 5 degree, within the 5 degree there are 12% ganglion cells, within 10 degree 34%, and within 30 degrees 70%. In the glaucomatous field, very rarely we can find the defect only beyond 70% but not inside. So we are more concentrated on central 30-2 or central 30 degree. This is the central 30-2 program where there is 76 points are distributed in 30 degree area, and in 24-2 program where the points are distributed in the 24, including the 2 nasal in 30, which I will tell you later on. So the pattern of the area are different, either central or the peripheral. It may be 30-2, it may be 24-2, it may be 10-2. This is the 24-2 versus 30-2 program, which we usually always look after. Sometimes somebody are preferring 30-2, but we are preferring 24-2. Why? It is 54 points in 24-2. Basically, the time management. It decreases the overall time the subject needs to perform this perimetric test. Here there are 30-2, and in 24-2 the peripheral points are eliminated, but the 2 nasal points are there, because the nasal points are definitely important in glaucoma management, that I will tell you later on. So just to recapitulate a little bit about what we know right now, what is threshold sensitivity, like the 50% time the patient is likely to respond for that. What are the prerequisites for doing perimetric test? What are the variations? Like the standard is white on white perimetry, others are like this. Types of perimetry are the threshold or screening test. The threshold is always preferable than the screening, but it will take more time. Sensitivity versus stimulus intensity, already I have discussed. The sequence of events. First, it indicates the foveal threshold, after that the 4 primary points, and depending on those foveal threshold and 4 primary points, the other points are detected. The printout format, either is the single field printout, the change probability analysis, the change analysis, or the overview. And the types of test, as I already told, the strategy or the threshold or the first pack strategy, something like that. Pattern, the area central or peripheral, whether the central 30, 24 or 10. Few more things you should know what is the strategy. Like the strategy, specifically there are 2 types. One is standard and over the first. This is basically just for the time management. In standard, 2 types, full threshold and SITA standard. In first pack strategy and the first pack in the full threshold first program, and SITA program is SITA first. Just choose test, which one you should do. Like if you think of standard threshold perimetry in 30-2, it takes about 14 minutes per eye, whereas in 30-2 SITA standard 8 minutes. Instead of 30 in 24-2, for the normal eye SITA program takes about 4 minutes, maybe glaucomatous eye a little bit longer. So you know about how much time it takes. Lesser the time it takes, it will be easier for the subject to cooperate. So, for ordering a test, you should keep in mind the time management, like as I told, threshold versus screening, how the threshold is done, whether it's full threshold or SITA strategy, how many points, whether 30-2 or 24-2, and whether it is reproducible. In the SITA program is as reproducible as full threshold takes and full threshold test, and it takes less time. So, usually in glaucoma management, we mostly do SITA standard 24-2. Again, few points, preferably one standard test. You should think of preferably one standard test for each and every patient, but there are some exceptions. Threshold test is always preferable than supra-threshold screening test, as I told before. Screening is sensitive in neurologically based field, just to find out the pattern of the field effect. In neurological, mostly rather than getting the exact threshold value, we want to see what is the pattern of the field effect. In the macular program, 10-2, because it is more concentrated, the peripheral is already damaged. In advanced glaucoma program, 10-2, with or without larger stimulus. In SWAP, in cases of the early glaucomatous changes, we can do software of automated perimetry. This is just a screening test. You can see these are the blacks are not seeing area, not seeing points, and these are seeing points. You can see the black area. You can get a pattern of homogeneous defect in this screening program. So you can test by a screening program where it takes less time to do a neurological field defect. In general, glaucoma related, if you have suspicion, don't do screening test rather than swab test. Specifically in glaucoma, standardized 24-2 SITA test we do. In neurological screening, better you can do the full field 81-point screening. It covers the wide area. In the retinal diseases like retinitis pigmentosa, better to do SITA standard 24-2, preferably stimulus 5, but if it is advanced 10-2, macular related only foveal threshold, or in cases of the macular threshold program, macular program or SITA standard 10-2, in the drug related cases it can, as I told, the red and white perimetry. In the functional malignity is determined binocular or monocular. Just to recap from the first part, the different strategy we know, the standard or fast strategy, full threshold versus SITA strategy, and choosing a particular test and ordering a test, what we should keep in mind during choosing or ordering a test. Now I'll go to the second part, which is the interpretation of a single field analysis. Especially I will concentrate on single field analysis because the time constraint. I will not concentrate on the progression analysis or change probability analysis or change analysis. 3 things you should ask. One is, by seeing this perimetry result, whether there is any abnormality. That is the first question. Second question, yes, we have found some abnormality, whether it is significant or not. And if I get some significant abnormality, whether especially if you are concerned with glaucoma, whether it is glaucomatous or not, especially whether it is localized defect or not, which we are more interested for. The first any abnormality. You need to exclude noise. What are there? You should see the reliability, you should see whether there is any learning effect or whether there is any artifact. Quickly I'll go to these things. Reliability, 3 things are tested: fixation loss, false positive and the false negative. There are some clues where by seeing the single field analysis you can get that this is the high false positive. There are some white photometers areas. The pattern deviation probability plot will be worse than the total deviation probability plot, and there is a high for numerical plot, there will be high sensitivity values and all those things. So 3 things you should look for: fixation loss, where the 5% stimulus are presented at the blind spot, where the subject should not see. But if the subject sees, then it is recorded as fixation loss. It is more, if it is more than 20%, in the printout you will get double cross. In false positive, the projector moves but there is no stimulus. But if the patient gives positive response, then it will be recorded as false positive, and if it is more than 33%, double cross will appear in the printout. In the false negative, already threshold pointed, there will be brighter stimulus presented, that is 9 decibel higher in the threshold pointed. If the patient does not respond, then it will be indicated as false negative response. If it is again more than 33%, double cross will appear in the printout. This is the high false negative. You can see that there are some areas where there is a white areas, and after that the whole thing is black. This is specifically, or this is characteristically a globally appearance in false negative, high false negative patient. What did the patient responded well when there are 4 primary points are tested, but after that the patient was tired or patient did not respond properly. So this is the high false negativity. There are some other noises like the learning effect. You can ask the perimetrist that how the patient responded, and at the same time there are some idea where the printout is getting. There are some defects in the peripheral points. After retesting the patient, you got the better visual field printout. This is due to the overhanging eyebrow in the superior field. You can get some defect. There are some like partial the ptosis, and after lifting the eyelid, you can get a totally normal field. This is the rim artifact. There are the absolute sensitivity values with a sharper border inside. This indicates the rim artifact. But if you want to use some correcting glasses with the rim, you can get this artifact like this. In case of refraction scotoma, if the refractive error is not corrected properly, characteristically it starts from the blind spot area, and in a wave-shaped pattern, the absolute sensitivity value is low. So this is the typical refraction scotoma, and in case of the small pupil, you can get the artifactually generalized depression of sensitivity. So these are the artifacts you should keep in mind, whether the patient is having the field effect is due to some artifact or artifactual field effect. So after excluding these things, you can think of that now I can go for whether there is any abnormality or not. If it is abnormal, whether it is significant or not. That significance will be given by StatPack analysis even, whether the measured sensitivity of value, what is measured here, is a defect or not. And if there is a defect, it is significant or not. That you will get by the numeric analysis of the numeric plot as well as the grayscale. The numeric plot shows the sensitivity values, and the grayscale shows some pattern of the defect, whether any area has got less defect in comparison to the age-related match, or this is the according the shapes are according to the decibel value, and you can just find out overally is there any pattern of field effect, or you can have some attention to this area that this is showing some defect. So in case of the artifactual field effect, also the grayscale is sometimes important. Now the measured sensitivity is a defect or not. That you will get with the total deviation plot. This is the total deviation plot. There are 2 plots. One is the numerical plot and one is the probability plot. In the total deviation plot, it is indicated how many normal may show that defect. Lesser the value, more is the significant. Just to elaborate these things, this numerical plot of the total deviation shows the age-corrected normal value, how much is the defect. So these are all you can see if there are some areas with the minus. So this is the numerical plot. But this deviation, whatever it is showing, whether it is significant or not, how you can know this. In the probability plot, it translates the value into shaded symbol. It indicates the statistical significance. How it indicates the statistical significance? If in any area, like there is a defect of maybe minus 9 decibel, whether this minus 9 decibel is statistically significant or not, that you can find out with the database what the machine has, that in a normal patient, how many patients may show this type of defect. In a normal patient, even the normal patients may show some defect. How many patients show this type of defect? If it is less, definitely that defect is significant. So that is indicated less than 5%, means 5 out of 100 patients may indicate this decibel value. So the significance of this you can know may be less than 5%. But here, if a shaded symbol is like this, then you can find out 5 out of 1,000 patients may show this defect. So this is less than 0.5% is more significant than less than 5%. You got this? If you do not get, just I can give you some idea, like if an area sensitivity value should be 18, 91.5% may show that sensitivity as 18. 0.5% means 5 out of 1,000 show that sensitivity area as about 12. So if you get that sensitivity in this area 12, that will be more significant than 16. So this indicates, by the shaded symbol, it indicates both the numeric and the probability plot, the statistical significance. What you know, you want to know. You want to know for the glaucoma point of view, okay, this is significant defect, whether it is localized or not. Because you are interested in glaucomatous field with some localized effect. So what this pattern deviation plot does, pattern deviation, there is a numerical plot and there is a probability plot. What the pattern deviation does? Pattern deviation does, if the patient or if the subject has any generalized defect, I need to know whether it is generalized or it is localized. It may be only generalized, it may be generalized plus localized. So in pattern deviation plot, it minuses generalized depression. How it is done? If a patient has a hill of vision like this, the darker area, and if the normal hill of vision is this, then you should see that if there is a generalized depression, then after adjusting this generalized depression, I can get this area or this hill of vision. So you can see the patient has a generalized defect. But if the patient has a localized defect here like this, in addition to the generalized defect, how you will get it? Then you need to know that, or need to subtract the generalized defect from this hill of vision, and then you will get this localized defect. That is done statistically in pattern deviation plot. How it is done? It is done, the 7th most sensitive point is adjusted to 0. And then from all points, there is some subtraction of those values. And then you will get the generalized height adjustment. So in the pattern deviation probability plot, in the same way, you can get a shaded symbol that in that area the defect is significant or not. So in total deviation plot, you will get that whether there is any defect or significant defect or not. In pattern deviation plot, you will get whether there is any localized defect or not. So the measured sensitivity is a defect that you have got with the total deviation. The defect is significant that you have got in the probability plot, and the defect is glaucomatous or localized that you will get in the pattern deviation probability plot. There are some other indices which I just quickly want to tell you about the global indices. In pattern deviation and the total deviation, the whole things are point by point. But in global indices, it is calculated by the overall, from the overall field. There's the mean deviation, pattern standard deviation, short-term fluctuation, and corrected pattern standard deviation. In the mean deviation, this is the average deviation value. This is the each point by point deviation is calculated. The average deviation value is denoted as the mean deviation of total deviation. That is the MD. In the pattern standard deviation, it is the index of the localized changes. Like the probability value, you can get some shaded symbol. In this is a index of localized changes. How the standard deviation of the total deviation is calculated? Means the deviation values are calculated the standard deviation, and that is defined the localized changes. Higher the standard deviation, higher the localized changes. So this is the pattern standard deviation. The other is the high short-term fluctuation. This is the intra-test variability. This is higher the short-term fluctuation, the inconsistent response is more. How it is calculated? Some areas are calculated twice, and the intra-test variability is calculated in that way. The last is the corrected pattern standard deviation, where the pattern standard deviation is adjusted for intra-test variability. So this is more important, the corrected pattern standard deviation. The last is the glaucoma hemifield test. The glaucoma hemifield test, we are more interested in glaucoma between the superior and inferior asymmetry. Here, in the glaucoma hemifield test, evaluates 5 zones in the superior field with the 5 similar zones in the inferior field, and it is represented whether there is any significant difference of asymmetry as outside normal limit, borderline, generalized reduction of sensitivity, abnormal high sensitivity, or within normal limits. There is some significance criteria from the Anderson's criteria, which indicates usually the glaucomatous defect with a cluster of 3 or more adjacent non-edge points. That is in a full treatment 30-2 program. But if you take 24-2 program, then it will be the edge points even also. Corrected pattern standard deviation in the global indices a value of less than 5%, and glaucoma hemifield test is abnormal. In 24-2, you can take the edge points along with instead of non-edge points. So, in interpretation of single field analysis, what we know right now, whether there is any abnormality, either abnormal, whether there is any significant abnormality, if it is a significant abnormal, whether it's localized significant abnormality or not. But there is something called glaucoma, whether this patient is having glaucoma or not. These patients may have glaucomatous field defect. But whether this patient is having glaucoma or not, that needs the clinical correlation. That is called the discrete correlation or structure function correlation, which is very important in significant management of glaucoma. What I always want to highlight, there is before any test, there is something called pre-test probability, which is defined as the probability of the target disorder, that is in our case like glaucoma, before a diagnostic test is results. The test result is known. That means before performing test, what is your suspicion? If it is high suspicion, then performing a test will be more value to you rather than just say, oh, okay, we should see how the field comes, then we will decide whether this patient is glaucoma or not. Don't do that. Whatever things or whatever parameters, whatever history and the clinical situation is available to you, you just find out whether this patient is having glaucoma or not, and then after that, if you do the test, that will be very helpful. But sometimes, just to confirm that test, it is helpful. So there is the most important thing is the disease evaluation. Much recent attention has been directed right now to the disc evaluation. So to make it easy, as I told before, keep your suspicion high by disc finding and the circumstantial evidences like IOP, the gonio, the family history and all those things, and then go for the visual field evaluation. Example, 17 years old male patient, he came with a history of IAC, the previous borderline CO tonometer reading, and the patient had open angle. You can see the disc. What you want to ask for or what you should do. Should you do a field test or not? This disc has a large cup, definitely, it may be glaucomatous. So I'll go for a field test. I've gone and the patient already diagnosed as glaucoma before also. I've got some field defect in this area. Now we'll be mostly concentrated on the pattern deviation probability plot to find out there is any localized defect or not. You can get this also defect. These are likely to be significant. So will you treat these patients? If you want to correlate all these things, I will just repeat this test. In the repeat test, I have found almost normal field. If you think, if you go back 17 years patients, how will he will develop glaucoma? He doesn't have any history of family history of glaucoma. And in case of the open angle, this patient should not have the eye ache. Even if these patients have glaucoma, should not have eye ache with a borderline stage. So if you go back and if your p-test probability is high, that probably these patients will have a large disc where there is isn't rule is maintained, inferior is wider than the superior, and it is almost symmetrical. I should find the normal glaucomatous field. And that's why I should repeat it rather than treating the patient depending on the first field. So this I want to highlight. If your pre-test probability is high, then if you go for glaucoma for perimetry test, that will be easier for you to interpret. So large disc, this patient has a large disc with a large radiological cup. A little bit of the glaucomatous visual field defect, generalized is very rare. Peripheral involvement, as I told you before, involvement first is very. They are in the glaucoma without involving the central. There may be sometimes the early paracental defect. And in the glaucoma visual field defect, it respects the horizontal meridian. As I told you before, if there is an inferior nerve fiber layer defect without any defect in the superior, it will always respect the horizontal meridian. As opposed to the neurological, as I told you, the neurological field defect respects the vertical meridian instead of the glaucomatous field defect which respects the horizontal meridian. How we think of the glaucomatous defect or how the glaucomatous defect field defect occurs? Usually in the arcuate fashion, if you get some arcuate defect which starts from the blind spot and then go in the arcuate fashion. So these are all like arcuate defect. But these are not likely to be glaucomatous because again, if you get arcuate defect, if it has definite nasal side widening of that field defect, then you can think of that arcuate defect is likely to be due to glaucoma. So not only the arcuate defect is, if it has a nasal widening, then arcuate defect is likely to be glaucomatous. Next is the definite nasal step due to the horizontal rapid. These are the definite nasal steps, like you can think of superior and inferior asymmetry. Third is superior and inferior field asymmetry. As I told you before, that you can see the all this there are gross superior inferior field asymmetry. The fourth point, sometimes we cannot get whether this is due to the neurological or the glaucoma in advanced cases. You will get in advanced cases there will be residual inferotemporal island. This is not inferotemporal island, this is not inferotemporal island. These are likely to be neurological rather than this, which is likely to be glaucomatous. So there are four defects within the arcuate pattern, whether there is a definite nasal step, superior, inferior hemifield asymmetry, and in advanced cases, residual inferotemporal island. So to interpret the single field analysis, I always tell a stepwise approach. Find out the reliability, whether it's okay or not. Exclude the learning effect or any artifactual defect just overall by seeing the base element. Whether there is any significance, you can think of Anderson's criteria, whether the significant defect is falling, it's just subtracting the Anderson criteria, and that is due to glaucomatous or not. Next, the glaucomatous pattern, what are 4 points I always tell, and the clinical correlation. Sometimes we cannot correlate clinically, and then we go back whether this is due to the learning effect or artifactual. Quite often it happens. Just few examples. I don't want to ask you rather than telling what is this. If you get a disc like this, you can think of there is some inferior and superior. The inferior is smaller than the superior. So you may get accordingly there is some inferior nerve fiber defect, and you may get some defect in the supratemporal area, and you will be happy with this. And this has a definite nasal step, so likely to be this patient is having glaucoma, this kind of glaucoma field. If you get a field like this, what you will think of? You will think of a normal disc? Likely to be. May not be, because there are some edge points. If you get a field, if you get a disc like this, which is maintaining the isn't rule, you can think of inferior is wider than superior. It is likely to be normal, and you can think of other circumstantial evidences like AIOC, whatever the Borneo, family history, and all those things. If you get a disc like this and a field defect like this, What do you know? It's not observing the Anderson's criteria also. There's some a little not in the arcuate fashion. May not be glaucoma, inferior. I don't know whether there is some inferior non-fibrillary defect, but there is some generalized pallor. To tell you frankly, this is respecting the vertical meridian, and this is a junctional scotoma. The patient had a pituitary and the other eye is almost lost. So this is respecting the vertical meridian, and that you should think of. The same thing as I told you before, there are some inferior, maybe some superior thing. The inferior thing is absolutely there. I'll be happy getting this field defect like this. What about this? Happy? This is okay. The field is okay. Normal, so likely to be normal. Even if it be the patient is high IOP, we can think of ocular hypertension of this patient.
Sorry, you have 5 minutes, please.
Yeah. What about this? It's likely to be normal, and I just magnified this image so it looks like this. But this patient is having inferior, superior, inferior asymmetry and almost inferior blockers. Go a little beyond this. This patient is having DRBO where the laser has been done. So it's not always the disc, it's a little beyond the disc also. What about this? This disc, it looks like a large cup. You can think the cup is almost this and this. But we are getting the field effect, not even the Anderson's criteria being taken. Should we repeat this field? This is a reliable field. And the Anderson's criteria, as I told, it's not observing the Anderson's criteria. The other of these patients, it looks like definitely glaucoma, large cup. But with this inferior thinning, the patient is having a field defect is very little, frankly. It's significant and it's correlated with the field defect. This is the right eye and this is the left eye of this patient. The field is like this. Here I will interpret these patients have a large cup to start with. Patients have glaucoma, but not to like the glaucoma, you should be afraid of a sudden reduction of IOP and all those things. The patient starts with a large cup, and after that the patient is having glaucoma. In a little bit, as I just want to repeat again about this is the glaucomatous which respects the horizontal meridian, and this is respecting the vertical meridian. What about this disc? Can I ask any one question like this? What do you think? This patient is having borderline IOP and the disc is like this. I did not think this patient should be, I'll get the glaucomatous field defect. I did not think. In the left eye I have got this field defect. I cannot ignore this because it respects the horizontal meridian. There is some nasal step and there is superior inferior asymmetry. Then I went back and I saw the field, I saw the disc. There is some non-fibrillary defect here. So you should look for that. Here also, the large cup with large disc have got a field defect like this. There is some non-fibrillary hemorrhage here. So if there is no correlation, go back and see the disc, and even the red free photograph also will be helpful for you. In pseudophakic glaucoma, persistently the patient is having some paracentral scotoma, and finally I have got a field like this. And this patient, probably the disc is not like glaucoma or glaucomatous, in OCT is also normal. What about this? The cup is not that much well defined, but there are some generalized as well as temporal pallor. So think for, if you get the field, you may get some neurological field like the centrocecal scotoma. This patient is having hereditary optic atrophy. What about this disc? Small tilted disc, but definite arcuate scotoma. There are some situations where the physiological variation will give you a field defect like glaucoma field defect, the arcuate pattern. There are a lot of neurological conditions also that can give arcuate pattern. So you should think of making conditions, and you should not depend on single criteria or clinical criteria to find or to stamp that patient as the glaucoma. This is my mail number. Anyone is interested, you can just send me any query. For that, I especially acknowledge my mentor, Dr. GC and Dr. Mandal, and my friend, Dr. Sood also, from whom Dr. Sood taught me how to interpret the visual field. my previous institute, MGMI Institute, and the help I have got from primers and of course my patients. Thank you very much.
Thank you very much.